Assalamu alaikum. Good morning, good afternoon, and good evening, depending on your time zone. Second lecture of tonight's session is about pediatric pneumonia. Let me find it here. I hope you guys can see it. Yeah, I know you can see it now. All right. So, learning objectives, what you should be able to do on the exam day. Recognize pediatric pneumonia patterns. So remember, when we are dealing with the pneumonia in pediatric population, it is viral versus bacterial versus atypical. So we need to know which one is which. We will discuss every single one of them. So basically, when you're dealing with pneumonia in pediatric population, remember these three things. It is either viral, or it is bacterial, or it is atypical. So based on these types, the treatment and approach is different. So we will talk about it. Use severity markers. Tachypnea. Remember, tachypnea is one of those markers that's very important to know if you're dealing with the respiratory issues. Like if you have tachypnea and the patient's respiratory rate is above 30, it means the patient has to be in ICU, because that shows the patient that shows the respiratory failure is imminent, and it will happen if you're not taking care of the patient as soon as possible. Hypoxemia, work of breathing to decide outpatient versus admission. Again, if you know that the tachypnea, hypoxemia, and working of breathing, then you would be able to approach the patient in a very healthy way. It means you would be in a better position to decide, should I treat the patient as an inpatient or should I treat the patient as an outpatient? Obviously, if the patient has respiratory rate above 30 and the patient has pneumonia, I will admit the patient. So select age and age-appropriated empiric therapy. I made a mnemonic to make it very easy for you guys. Otherwise, it's going to be very confusing. Based on age, you will forget which one is which. But I made a mnemonic and made it very easy to understand and go for the right antibiotic. So neonates, for them, which antibiotic is the best? 1 to 3 months, and 3 months to 5 years, and then above 5 years. So these are the things that we will focus on this lecture. Identify high yield special cases: chlamydia, trachomatis, mycoplasma, pneumonia, which is usually common in school age. Anywhere above 5 years of age will be common. 7 is the commonest age. Effusion and edema. Apply stewardship, supportive care when viral likely, narrow antibiotic when bacterial likely, avoid routine, repeat X-ray. So these are the things that we will discuss. Now let's go one by one. Very important, inflammation. So the definition: inflammation, infection of the lung parenchyma with the alveolar inflammation and sometimes consolidation in children. Etiology is strongly age dependent. We will talk about it. So now let's talk about viral versus bacterial. Viral. Viral is diffuse bilateral. Please remember this: diffuse bilateral streaky prehilar or interstitial pattern plus minus wheeze. It is very common and less than 5 years of age. So usually if they give you a scenario about a kid who is less than 5 years of age and the patient has sign and symptom of pneumonia, but when you do the X-ray, you find diffuse bilateral streaky or prehilar or interstitial pattern, and the patient has wheezing. Think about viral. So you don't have to bombard the patient with antibiotic, okay? Bacterial, higher fever, the patient would be more toxic, focal finding, and lower consolidation. That's the clue and characteristic X-ray finding or radiographic finding, plus minus pleural effusion. So pleural effusion could be positive, could not be positive as a complication of untreated pneumonia. But if you treat the patient at the right time, at early stage, that will not happen. But Remember, viral is very common. If there is a question in MCQ1, what is the commonest reason or the common type of pneumonia in pediatric population less than 5 years of age? It is viral. Okay. If the patient is more toxic, feverish, and the patient has focal finding and also lobar consolidation, think about bacterial. Most sensitive clinical marking, tachypnea. Remember, that's the most sensitive. That's the most sensitive. That's why I made it red, and we did mention it when we were doing some cases in PGP. It's often the earliest and most sensitive sign of the lower respiratory disease severity in children. It means the patient gets worse if the patient respiratory rate is above 30. So the clinical feature of the viral, if you notice, this is how diffuse bilateral streaky prehilar or interstitial pattern plus minus V is common. So this will be characteristic finding of the viral, but bacterial, the patient will have higher fever, more toxic, focal finding, like this. Okay. Now let's talk about age-based etiology, very high yield neonate. When we say neonate, anyone less than 28 days is considered as a neonate. Like that is the time that you need to be very, very cautious about your treatment. Anyone with a fever at this stage has to be admitted. Any neonate less than 28 days old with any kind like fever, with whether you know the reason or the source of that fever, the patient has to be admitted. That fever is indication for admission. Okay, so what is the pathogen? This might be in the licensing exam. They may ask you the pathogen based on the patient's age. Usually, if you have a baby who is 28 days old, anywhere within the first month of life, it is group B streptococcus. The second most common is E. coli. The third one is Listeria. Sepsis-like non-specific signs. These will be in the clue in the scenario. Again, less than 28 days, fever, straight to the hospital. Then you do the investigation and find the reason, whatever it is, then you treat, okay? Now, let's say the patient is 1 to 3 months. Streptococcal pneumonia, Staphylococcus aureus, chlamydia, staccato cough. Staccato cough suggests chlamydia. What does it mean? It means it is a repetitive short cough that sounds like a series of single coughs with the inhalation. So that is what it means. 3 months to 5 years, then it could be virus most commonly, bacterial, and streptococcal pneumonia. Usually, if it is viral, the X-ray will show diffuse streaky. If it shows lower consolidation, then it will be bacterial. More than 5, usually streptococcal pneumonia, mycoplasma pneumonia, chlamydia, and the patient will have subacute cough, interstitial, plus it is atypical. When we say atypical, remember the patient will have sign and symptom of pneumonia, but they will have an atypical symptoms or sign as well. For example, the patient will have headache. Headache has nothing to do with the pneumonia, but it appears to be present in the child. If you have a child who has cough, who has sputum, who has all signs and symptoms of pneumonia plus headache, that headache is pointing toward atypical pneumonia. IMG exam tips. Start with age. Choose the most likely bucket, viral versus bacterial. We did talk about that. Then choose the therapy accordingly. So initial management, always, if they are asking you what is the best initial management, it is always supportive therapy. So it will be hydration, oral, IV, depending on the feeding and work of breathing, antipyretic for comfort, oxygen to maintain appropriate saturation, nasal suction, airway clearance and fan as needed, monitor respiratory rate. Why? Because this is the most sensitive marker. retraction, grunting, feeding, urine output. When supportive care alone is enough, when? Like we don't have to do nothing else, when we just stick only with the supportive therapy. Short course illness, diffuse, streaky pre-Heller pattern in the X-ray finding. The patient has wheezing, but the patient is a stable oxygenation. The patient does not look toxic. Safety net and statement return urgently for worsening work of breathing, poor feeding, lethargy, cyanosis, or persistent fever. That's something that you need to remember when you're doing the consultation in NACOSCI. Like when you do the consultation before you say goodbye, you need to make sure that the patient understands what are the points that he need to know, that if they appears, the patient has to bring his kid back to the emergency room. For example, if the breathing gets worse, if the patient cannot eat or drink, if the baby is getting lethargic, if the patient develops cyanosis, if the fever persists beyond 72 hours, or if it gets worse despite the proper treatment, then the patient has to be brought back. Severity and disposition. Okay, now in this slide, we decide how to treat the patient, in which condition as an inpatient, in which condition as an outpatient or an ICU. Admit if the patient has hypoxemia, obviously, very important. As I mentioned before, tachypnea is the most sensitive marker. Moderate to severe work of breathing, apnea, dehydration, poor feeding, toxic appearance, unreliable follow-up, very young infant. Like if it is less than 28 days and fever, the patient has to be admitted. Tachypnea trend, increasing respiratory, suggests worsening severity or fatigue even before other signs. So it is the sensitive and the earliest sign of respiratory failure in a patient who has pneumonia, especially if it is very young. But it is also accurate in adult as well. So setting, outpatient, typical picture, mild, stable, oxygen saturation is okay, feeding is okay. So why would I bother admitting the patient, right? So what I do, oral antibiotic, if bacterial, likely, and plus follow-up. If it is viral, not bacterial, then in that case, we just do supportive treatment as an outpatient. Now, inpatient or ward needs oxygen. If your patient is hypoxic, needs oxygen, then you have to admit the patient. If the patient cannot eat and drink, obviously you have to admit. These are the admit indication or admission indication. Now, ICU, impending respiratory failure, apnea, and shock. Escalate the respiratory support plus treat causes. Diffuse, these are the clues. Remember, characteristic X-ray finding. So X-ray interpretation. If you see diffuse, streaky, pre-Heller, it is viral, treated as such, supportive, not antibiotic, unless it's complicated or superimposed with infection. Lobar consolidation, remember it is typical bacteria, pneumococcus, so you start amoxicillin as an outpatient. Pleural effusion, it is complicated, again, you treat it as such. Interstitial, school age, it's atypical, consider macrolide. For atypical, we usually start azithromycin. So exam trap, wheeze plus diffuse pre-Heller streaks in infant usually support treatment because it is viral disease. Avoid reflex antibiotic unless bacterial signs emerge. So it means if you see anyone less than 5 years of age and the patient has wheezing and also the characteristic finding of X-ray, which is the pre-Heller or diffuse streaky pattern, then in that case, just treat it as a viral infection. Neonate, L. So for this one, if you notice, A. So this is a mnemonic that I made for it, like 4 A's, based on their age. Based on their age. If you have a baby less than 28 days old, and the patient has pneumonia, ampicillin plus gentamicin. A, ampicillin plus gentamicin. If the patient is 1 to 3 months old, again, ampicillin plus ampicillin or ceftriaxone. Ampicillin or ceftriaxone. You can also add macrolide if chlamydia is suspected. If not, that ampicillin or ceftriaxone is more than enough. 3 months to 5 years. Again, amoxicillin if you're treating as an outpatient. If you're treating as an inpatient, then again, ampicillin or ceftriaxone. Same thing like 1 to 3 months. So, ampicillin gentamicin, ampicillin or ceftriaxone, ampicillin or ceftriaxone. If outpatient, both of them amoxicillin. If chlamydia is suspected, add azithromycin. More than 5, usually, if it is atypical, usually azithromycin. But if it is not atypical, again, amoxicillin. Avoid IV broad agent in a stable outpatient. Use the narrowest effective regimen and reassess in 48 to 72 hours. Always for any infection, when you're treating the patient, you need to reassess the patient and reassess the sign and symptom to see if the patient is improving or not within 48 to 72 hours. If the patient is not improving after 72 hours, it means that you're treating the wrong condition. It means you have a wrong diagnosis, or the patient may have resistance to type of antibiotic that you choose. So you need to reconsider your diagnosis and do a further investigation. So that is the mnemonic that I made: ampicillin plus gentamicin, ampicillin or ceftriaxone, ampicillin or ceftriaxone, and azithromycin. So all of them starts with A, okay? All starts with A. So special cases, like let's say age, typically 1 to 3 months, the glue staccato cough, which is again those small and repetitive cough, afebrile or low-grade fever, interstitial X-ray, often associated conjunctivitis history may be present, treat with macrolide. So this is a characteristic finding of chlamydia. Okay, if they want to test you on that, they will mention this, either the name, or they may indirectly mention how they cough, like very small, dry, repetitive cough during inhalation. And then they might also add the patient has a history of conjunctivitis. And then you should be able to pinpoint it and choose the right medication, which is the azithromycin. So when it comes to azithromycin, I think I do have a slide here, so I'm not going to bother you guys. It's coming up. So why beta-lactam fails? Chlamydia is intracellular. Standard beta-lactam do not provide reliable coverage. So in that case, you can add azithromycin. If you have someone that's not responding to amoxicillin, azithromycin should be added. Exam wording: 2 months infant plus staccato cough plus interstitial X-ray. The best choice is azithromycin. So this might be one of the scenarios that you might get in the licensing exam. Now, antibiotics that you need to avoid in neonates less than 28 days. This is very important. You have to know, and please memorize it before you go for the licensing exam. Ceftriaxone, you cannot use it if the baby is less than 28 days because of the connectress risk. Sulfonamide, trimethoprim, sulfamethoxazole, same reason. Chloramphenicol, gray baby syndrome, immature hepatic metabolism, cardiovascular collapse. Tetracycline, doxycycline, teeth bone effect. These teeth are gonna start discoloring. Fluoroquinolones, ciprofloxacin, or any of them, levofloxacin, concern of cartilage, tendon toxicity, use only when no safer option. Actually, for the fluoroquinolones, you have to be very careful not to use it to anyone less than 18 years of age, especially if the baby is less than 28 days. That's a no-no, okay? Unless you have no other choice. Aminoglycosides, again, gentamicin is one of the best choice medication that is used in combination with ampicillin for pneumonia. But remember, we should use it with caution. It is not avoided, but we have to use it with a caution. Not avoid, but requires careful dosing and monitoring due to nephrotoxicity and ototoxicity risk, commonly used safely with monitoring. So this is not something that you have to avoid, but this is something that you need to be very cautious when you're using it. Special cases, atypical pneumonia in someone who is above 5 years of age. So subacute course, prominent cough, mild fever, headache. Remember, so they will give you this, and on top of all of that, they will add a headache. And probably sometimes they also malaise. But usually headache. Exam may be mild. Chest X-ray often interstitial or patchy. This is very important. Patchy infiltration. This is characteristic of the atypical pneumonia. Most likely mycoplasma or chlamydia. Treat macrolide when atypical likely. When to add beta-lactam to mixed picture. If you have a mixed picture of lobar and interstitial, remember, in this two condition, you can add amoxicillin plus azithromycin. If you have combination of these two, a mixed picture of lobar and interstitial. Let me make it bold and red. Okay, lobar plus interstitial or higher severity, then in that case you combine for the lobar amoxicillin, for interstitial azithromycin. Avoid pitfall. Macrolide monotherapy is not ideal for classic lobar pneumonia. For that you have to use amoxicillin. Complication, think complication if the fever is persistent, pleuritic pain, worsening dyspnea, decreased breathing. Chest X-ray ultrasound, if it shows pleural effusion, consider loculation on ultrasound, significant effusion, thoracocentesis, obviously, impemo suspect, source control, drainage plus antibiotic. Exam, next step, moderate effusion. The next step always for moderate effusion is thoracocentesis. Do not wait. Clinical reminder, antibiotic alone may fail in the pleural effusion. So you have to do the antibiotic plus drainage. Do not rely only on antibiotic. Okay, stewardship and follow-up. Do not over-treat viral disease. Obviously, we know that, so I'm going to skip it. No routine repeat X-ray. Obviously, we know that X-ray might take 6 to 8 weeks to like everything gets back to normal. So you don't have to keep on doing the X-ray, or the X-ray changes is not going to happen as soon as you see the improvement in sign and symptom. Sign and symptom improves, but if you do the chest X-ray, the chest X-ray still will be abnormal, and it will be abnormal up to 6 to 8 weeks. So don't waste your time and do not expose the patient to unnecessary radiation. Antibiotic selection rules, lower. If it is lower, so that is a clue. If you see there is a lower finding in X-ray, amoxicillin is an outpatient. If it is inpatient, obviously you have to start ampicillin or ceftriaxone or ampicillin plus gentamicin based on the patient's age. Atypical, more than 5, macrolide, azithromycin. Neonate, again, when we say neonate, less than 28, ampicillin plus gentamicin. Always reassess after 48 to 72 hours for response. So now let's work on some cases. 2 months infant, staccato cough, mild fever, interstitial X-ray finding, stable oxygenation. And this is what? Chlamydia. What do we do? So here, what is the MCQ 1 once? It means the diagnose. What is the diagnose? It is chlamydia. What is the best treatment? Azithromycin. The key age for this chlamydia is usually age 1 to 3, and the patient is 2 months old. And the key characteristic is staccato cough. Avoid. Do not choose amoxicillin alone if the chlamydia is clearly signaled. Beta-lactam do not cover it. So if there is a combo or a mix, please mix the antibiotic as well. Case number 2, you have a patient with fever, cough, tachypnea, mild, X-ray diffuse bilateral. So if it is bilateral streaky prehalar infiltration, it is what? Viral. For viral, what do we do? Supportive. Why tested? Viral pneumonia is most common in less than 5 years. Avoid unnecessary antibiotic. Okay. Now, case 3, 7 to 6. If it is 7 to 6, think about 2 things. Either it is mycoplasma pneumonia or chlamydia. So for these 2, low-grade fever, headache, atypical, non-toxic, patchy infiltration, question, best empiric antibiotic. So best empiric, if the patient has headache, it is atypical finding. For atypical pneumonia, what do we do? Azithromycin. Do not default to ceftriaxone IV in a stable outpatient. We never use IV ceftriaxone for obviously, it's obvious. All right, so step 1, ask what is the age? Neonate versus 1 to 3 months, 3 months to 5 months, or 5 years or more than 5 years. Very important. In this slide, these are the things that if you're dealing with pediatric pneumonia, that you need to ask before you start deciding for the treatment or investigation or consultation. So first of all, you have to know the age, because it's very important. Based on age, you can decide the antibiotic, right? Very important. So age is number 1. Number 2, the pattern. Is it diffuse streaky and the patient has wheeze? So I'm dealing with viral. Is it lower consolidation? I am dealing with a bacterial. Is it interstitial patchy? I'm dealing with atypical, a mycoplasma or chlamydia. In terms of severity, trend, tachypnea trend, oxygen, WOB, feeding anhydration. Plan supportive antibiotic, admit if hypoxemia, dehydration, and reassess. Always reassess after 48 to 72 hours. Now, under 5, viral causes most common, which we did talk about it. These are the things that we have to memorize. Tachypnea is a key early severity marker that we have to decide that the patient has to be in the hospital. Neonate pneumonia, if it is less than 28, ampicillin, gentamicin. 1 to 3 months, consider chlamydia if the patient has this type of cough. Lower consolidation, always typical pneumonia. Amoxicillin outpatient and IV inpatient. More than 5, then this is interstitial infiltration. It is atypical macrolide. Pleural effusion, obviously we have to do the thoracocentesis, and we have to reassess. I think this is something that you have to know. I think I do have all these in the slides. So let's stop it here and start doing some cases.